Thank you, organizing committee, for giving me this opportunity. Topic for the session is essential in chronic urticaria in children, for which I invite Dr. Krishna Mohan, consultant pediatrician, Kerala Government Health Service. He is also state secretary, IAP Kerala. Over to you, sir.
Good morning. So at the outset, let me thank EAP Pathanamthitta for giving me this opportunity. So this is a very short talk. It is only 10 minutes, so I have to go really fast. So regarding essential urticaria, the definition of urticaria, all of you will be knowing, it's an erythematous, pruritic, raised wheal that branches with pressure and resolves without residual lesions, and it is transient. And to start with the classification, what is the definition of chronic urticaria? The cutoff time is 6 weeks. Any urticaria which lasts more than 6 weeks we take as chronic. And in chronic urticaria itself, we further classify it into chronic inducible urticaria, which is only 20%, and a large chunk is formed with the chronic spontaneous urticaria, which comes to around 80%. And this chronic spontaneous urticaria itself, we can further divide into those with a non-cause and without any cause. And inducible urticaria, all of you may be knowing, it is due to some inducible factors like pressure, temperature, vibrations, all of some different things like that. So in the next few slides, I will tell about a bird's eye view of some of the important types. So this one is very common, dermatographism. All of you would have seen this. It's a common physical urticaria presenting in 2 to 5% of the population, and the mucous membrane is usually unaffected, and there is no specific treatment for this. And only thing is that avoid friction, scratching, and always use loose clothing. This is a very important type of urticaria, which is called as the pressure urticaria, and it is often sometimes even misdiagnosed as a fever of unknown origin, because I had one patient who presented with a case of fever only during night time, only at when every day 9 o'clock the child is getting fever after coming to the school, and no other history, no other symptoms, no other investigations were positive. The only thing is that he develops a rash on both sides of this shoulder, and parents didn't think about pressure urticaria because it is developing only at night. So the thing is that it is a delayed pressure urticaria which develops 30 minutes to even 12 hours after the pressure. So it can severely interfere with the quality of life, and the systemic features are very important. Sometimes it presents with flu-like symptoms, may present with fever and even joint pain also. It can be painful or pruritic, and once it develops, it can persist for 2 or 3 days also. This is another thing, cold urticaria. Here the inducing factor is a cloud exposure. So you can diagnose it by doing a test, what is called as the ice cube test. So you have to keep an ice cube over the forearm for 5 minutes. Even if you, without any, a normal person also, you will get a redness, but for a person who is having cold urticaria, you will get a definite induration and itching also. This is a very, very rare form of urticaria, what is called as aquagenic urticaria. So it is who is allergic to water. So it is extremely rare, but it can be a dreadful condition also. Sometimes these type of patients can even develop anaphylaxis. So after taking a bath in a swimming pool or something like that, he can go in for anaphylaxis also. So this is a rather common condition. I will tell a case, a 11-year-old boy who develops papular pruritic rashes after coming from playing. So this is a type of cholinergic urticaria where you get a, unlike the common urticaria, the lesions here will be maculopapular with itching, mostly concentrated on the trunk, neck and limbs. And here the triggering factor is the exercise or even emotional stress. It resolves within 1 to 2 years. This is another case, a 9-year-old male child who presented with extremely itchy, blotchy rash all over the body for the last 7 weeks. Each was lasting less than 24 hours, varying in size, not painful, and is not leaving any scars. There is a history of ITP in the same child, and he was treated with IVIG for 2 days, and all. There is a history like that. and his IgE was almost normal, only 87. No other findings were positive, but on doing a thyroid profile, including the T3 and T4, these antibodies against the anti-thyroglobulin were positive. So that is another very common type of cause for this chronic urticaria, autoimmune. So chronic spontaneous autoimmune urticaria is not also uncommon. Here what happens is that autoantibodies directed against IgE receptor or IgE itself will occur, and they will lead to the cross-linking of the IgE receptor and degranulates the mast cells. And in this type, around 15% can be due to a thyroid-related antibody. So how will you approach a case of chronic urticaria? So like in any other allergic disease, history is the most important thing. So we have to ask about the time of onset of the disease, how it is presenting. Is there an angioedema? That is very, very important, because sometimes the child may be having an associated angioedema also. So that is very important. Are there any other associated symptoms like a bone involvement or a joint pain, associated fever? All these things will always point towards an alternate diagnosis also. You should also ask about the family history and personal history, and occurrence in relation to menstrual cycle. Sometimes, especially the adolescent girls develop urticarial lesions during menstrual. That is due to an effect of progesterone. And occurrence in relation to foods and drugs. NSAIDs are one group of drugs which are notorious for producing this type of urticaria. AC inhibitors can produce both urticaria as well as angioedema. Because of the increased levels of bradykinin, it can lead to angioedema also. Occurrence in relation to infections. Stress is very, very important. Stress, around 25 years back, when we were kids and all, stress was not a big problem. But nowadays, stress is a very, very burning issue, even among small kids. When we studied around 25 years back, stress was the term was there only in physics. But now everybody is having stress. So stress also is a very, very important thing. So social and occupational history, leisure activities, the treatment history, all these things we have to ask. Now, assessing the severity, we have a scoring system called the UAS7, that is Urticaria Activity Score 7. So this is a scoring system which considers the number of wheals and the extent of pruritus. And scoring is done like 0, 1, 2, 3 like that. And you score it for 1 week, and at the end of 1 week you take the composite score. So it is scored from 0 to 42, and the severity is based upon how large this number is. Now coming to the last part, how will you test and how will you treat? So testing for chronic spontaneous urticaria. What is the testing for acute urticaria? For acute urticaria, you keep in mind there is no need to do any investigation. But for chronic spontaneous urticaria, you can do a set of investigations, but you should be clear in your mind that you need not do unnecessary investigations. You can do some routine investigations. So what the latest EACI guidelines from 2021, what they are recommending is that the basic investigations that you can do is only CBC, ESR or CRP, urinalysis. Beyond that, only depending upon the history, you need to do the further tests like an thyroid peroxidase antibody test that you can do, the total level of IgE, and the further test depends upon the individual case. So allergy testing, is it required? Actually, it is not required because it is a unnecessarily done test in many of the cases.
So 2 minutes.
2 minutes, okay. So it is usually done unnecessary for many conditions. You should always remember that food is a rare cause of chronic urticaria. Food materials can cause, food allergy can cause an acute urticaria, but for chronic urticaria, food is a very, very rare cause. So there is no need to do the panel of allergy tests in conditions like urticaria. And these other tests, only depending upon the individual cases, if you suspect, you can do these tests. Chronic inducible urticaria like the physical urticaria, based upon the history, if you get a history that cold exposure is causing, then you can do the ice cube test, or pressure urticaria, you can keep a weight over the hand or the forearm for some time and check that. So these are inducible urticaria. There are specific recommended tests by the EACI, and depending upon history you can do. So coming to the last part, how will you manage? So management is based upon certain principles. The first and foremost thing is that identify and remove the causative agent or trigger. Treat as much as needed and as little as possible. And just like where you treat asthma, you have to go for a step up or step down approach. And the most important drug in pharmacotherapy is the second generation H1 antihistamines. So like our cetirizine, levocetirizine, fexofenadine or bilastine. And it has to be taken regularly. How long you give the drug is a very important thing, because in chronic urticaria, the mistake which occurs is that when the patient comes, many of the practitioners prescribe the drug for 3 days or 5 days or 1 week. That is not enough. You have to give at least for 1 month if it is a case of chronic urticaria, if you have diagnosed. So if you stop at the end of 1 week, definitely the symptoms will come back. So this is the latest international guidelines given by the IACI. So the first drug that you are supposed to start is the second generation H1 antihistamines. And if there is inadequate control after 2 to 4 weeks or 1 month or earlier, the next step you are supposed to do is that you increase the dose. First you can double the dose and you can even make it 4 times. So what is the dose? Dose means the recommended dose by the manufacturer. So this is a very, very important point, because sometimes if you give fexofenadine, if 30 mg is the recommended dose, if you give 4 times, it comes to 120. So when you give, you make sure that you write it down as per this protocol and recommendation you are giving, and you also counsel the parents regarding that you are giving a higher dose. Otherwise what will happen is that the medical store person will tell, doctor, dose I had many patients who came back or called back in phone and told that dose you have to counsel them clearly. So that is the second step. You can increase the dose to 2 times and then 4 times. And even with that, if the child is not improving, the next step is omalizumab. Omalizumab, very rarely we need to have to start omalizumab in chronic urticaria, because even by doubling or even in the normal dose, if you continue for 1 or 2 months, the symptoms will come down, the patient will be okay in majority of cases. So even after 4 times increasing dose, child is not improving, you can go for omalizumab. And if the patient is not improving with omalizumab also, the last drug which is recommended is cyclosporine. So this is another test which will help you to follow up the patient, and this is a history based thing. With the patient or the bystander has to fill this, and based upon the scoring you can see how far the child is controlled or not. So if it is, the score is less than 12, it is an uncontrolled case, and if it is 12 to 15 it is well controlled, and 16 or above it is completely controlled. What about steroids? This is one drug which is commonly misused in urticaria. Any urticaria case, patient, the doctors will start on steroids. But this should be used in chronic urticaria very carefully, only for less than 5 days. In a short course, in a dose of 0.5 to 1 mg per kg per day. It is even lesser than what we give in asthma. In asthma, we give 1 to 2 mg per kg per day. This is 0.5 to 1 mg per kg per day for a maximum of 5 to 7 days. This is about omalizumab, as I already told. Very rarely we need to. I have used this omalizumab in a chronic urticaria patient for only once in my lifetime, because even without starting any other drug, just with second antihistamines alone, you can get good control. So omalizumab, the dose is 150 mg per month, and you have to give it for months together. The only issue is that it is very costly. A single dose will cost around 12,000 to 15,000 rupees. And you have to remember the dosing is independent of the total serum Ig. What is it? What is the relevance of that term, that sentence? In asthma, we take the dose of omalizumab based upon the levels of IgE. We usually follow a normogram, and based upon that normogram, we titrate the dose of omalizumab in asthma. But here, the dose is independent of the serum IgE. So these are the advantages of omalizumab. It prevents angioedema development and also improves the quality of life. About cyclosporine, the disadvantage is that it is having a very non-therapeutic safety index. It is, the dose is 3 to 5 mg per kg per day. be very careful when you start this thing because of the risk of nephrotoxicity. So this is the last slide. Natural course of urticaria. Urticaria is even if it is a chronic urticaria, it is self-limiting. 50% will get better in 6 months of time. Another 20% by 3 years. Further 20% by 5 years, and only in less than 10% it will persist for more than 10 years. So, in majority of cases in pediatrics, chronic urticaria in pediatrics itself it is very rare, and even if the child gets, if you treat properly on a stepwise approach, you will get very good control. So, spontaneous remission can occur at any time. Thank you so much.
Thank you, Dr. Krishna Mohan, for that lucid presentation. I think so. Urticaria is always a nightmare at times. I think so. Dr. Krishna Mohan will be available to take your questions at any time. We'll go to the next topic, and that is.